Hello, and thank you for joining us. Morning Commute is developed in collaboration with At Point of Care and Projects in Knowledge and is part of a continuing medical education series. This CME CE activity is supported by an educational grant from GlaxoSmithKline. Information about the faculty and disclosures can be found at morningcommutepodcast.com/COPD4. You can use this link to receive your credit and evaluate this program. The URL can also be accessed in the episode notes. In our ongoing 6-part series on COPD, diagnosis of patients with COPD, particularly using the GOLD recommendations and the COPD assessment test, was discussed in episode 1. Our second podcast took a look at dual therapy, and in our third, our experts discussed triple bronchodilator regimens and which patients would most benefit from this therapy. As we continue our discussion of therapeutics, our experts now turn to review the role of inhaled corticosteroids in the management of COPD. When should they be added to the therapeutic regimen, or when should they be stepped down? I'm your host, Candace Hoffman, Managing Editor of Morning Commute. We are joined by Dr. Jill Ohar, Professor of Pulmonary, Critical Care, Allergy, and Immunologic Medicine at Wake Forest University School of Medicine, and by Dr. Meilan Han, Professor of Pulmonary and Critical Care Medicine at the University of Michigan. Dr. Ohar will begin our discussion.
Hello, and welcome to our discussion about dual therapy containing inhaled glucocorticoids for COPD. Today, I'm joined by Dr. Meilan Han. Meilan, welcome.
Thank you so much, Jill. Happy to be here.
Well, let's talk about inhaled glucocorticoids. Let's just start out. We have actually single agents to treat COPD. We have dual bronchodilators to treat COPD. We have triple therapy that includes an inhaled glucocorticoid to treat COPD. How do you decide what should I be doing to treat the patient in front of me in clinic? How do I make that decision around all our choices available?
Yeah, I think the good news is that we have a number of choices available. So I guess the bad news is that we have to think a little bit more in trying to find the right agent for the right patient. So whenever I'm trying to make therapy choices, I always think about, well, is the patient on anything right now? And if they're not, then the ICS-LABA, or inhaled corticosteroid long-acting beta agonist category, really sits in the GOLD D group with respect to the GOLD recommendations for initial start in therapy. So if you've got a patient that is, treatment naive, but they're highly symptomatic, so it's a CAT score of 10 or more, and they're at high risk for exacerbations, that makes them a GOLD D. And if they're not on anything, GOLD actually allows for a couple of different options. Long-acting muscarinic antagonist alone is an option. Dual bronchodilator is an option, and inhaled corticosteroid LABA, as we're talking about here, is also an option. And in the latest iteration of the document, they emphasize that when we're thinking about trying to identify patients who would be appropriate for an inhaled steroid regimen, that baseline serum eosinophils can really be helpful in that regard. We've got just a set of accumulating data from multiple compounds and multiple studies that suggest the higher the baseline eosinophils, the more likely a patient is to respond. And so while there is no magic threshold, despite the fact that you're going to hear numbers thrown around, I think it's important to remember that relationship between baseline eosinophils and response to inhaled corticosteroids is really continuous. But the GOLD document suggests if you've got an initial start, if you've got eosinophils of 300 or more, that's a pretty high threshold, and that's probably a patient that really should be on an inhaled steroid off the bat. Now, if you've got a patient that's already on therapy and you're trying to decide what to do, let's say they're on a dual bronchodilator to begin with, and the problem now is frequent exacerbations. That, again, I think is another patient where the question is, would they benefit from inhaled corticosteroids? And I think here you really actually have a bit of an option. You can go up to triple therapy with 2 bronchodilators and an inhaled steroid, but in some cases, you may decide it's actually beneficial for that patient to actually do an across-the-board switch. in which case maybe you'd want to consider just an inhaled corticosteroid, long-acting beta agonist. And again, here's where I might let eosinophils sort of guide me in helping to think about where inhaled corticosteroids would be most beneficial. So that's kind of how I conceptualize it.
That's great. I think it's important to underscore the fact that regardless of what the eosinophils are, inhaled glucocorticoids as a single agent are never indicated for COPD. So clearly, an ICS in combination with a long-acting beta-adrenergic would be always what you would go with if you're going to use an inhaled glucocorticoid-containing product or a triple, but never as a single agent for a steroid alone. I think one of the things that you mentioned, and I find that it's very hard often to tease out symptoms versus exacerbations, and the recommendations by Gold really do try to make it black and white, and it's very difficult to find that patient who has the frequent exacerbations who isn't very symptomatic. And I think because the exacerbations beget symptoms, and so it's hard to separate out those. But clearly, if you have a patient who tends to have more breathlessness, I agree that the dual bronchodilator may be where to go before an ICS-containing product. And clearly, the ICS LABA may be for the frequent exacerbator phenotype that we've talked a little bit about in previous podcasts. I think when we also talk about the Gold management cycle and the concept of reassess and the idea that you can step up or step down, is there ever a case where you have someone who's on triple therapy and you go ahead and take them down to a dual, and that dual may be a LABA-LAMA or it may be a LABA-ICS? Is there such a circumstance that you've found in your practice?
You know, I think that one of the places where COPD thinking and asthma differs a bit is in that COPD is progressive. And so I think for many of us, the thought of stepping down in COPD sort of just didn't really occur to us, or at least I didn't think about it a lot, because why would you step down if things are only getting worse? My options here really are only to add. But we are starting to see some accumulating data, I think, about how to identify patients who may be at greatest benefit from inhaled corticosteroids, but also those who might be at greatest risk. So we know that inhaled corticosteroids are associated with certain side effects, and probably most notably pneumonia. And so if I have a patient where the inhaled steroid is starting to get to be a problem, they've had a few pneumonias, maybe they've just had multiple bouts of thrush that we can't seem to control no matter what molecular device I have them on. There may be instances, and in particular if the eosinophil count is low, where I just don't think we're really getting much benefit. You know, sometimes you also may see patients that have been stable, not had an exacerbation in quite some time, and again, you're concerned about risk. The data suggest that we've had two studies within the last few years, one Wisdom and the other one Sunset, which suggest on post-hoc analyses that the higher the level of eosinophils, the more likely the patient is to fail inhaled corticosteroid withdrawal. So if you're thinking about this and the patient has really high eosinophils, it makes that decision, I think, a bit trickier. But if you've got a patient with really just rock bottom eosinophil levels, there really may not be a great benefit to that patient to continue on with inhaled steroids, particularly given the side effects. So that is where I am, again, it's a very personalized patient, individual decision, but that's where I tend to think about inhaled steroid withdrawal.
So how about a person who's got a lot of side effects, who's on an inhaled glucocorticoid? Is that one that you might think about substituting a phosphodiesterase inhibitor, or is this the kind of person that you might want to think about starting azithromycin? to control their exacerbations? And if so, what kind of things do you check first before starting those kinds of drugs?
Right. So beyond the inhaled bronchodilators and steroids, what are our other options then if patients are still exacerbating? So as you mentioned, we do have PDE4 inhibitor roflumilast, which has been FDA approved for use in the U.S. And that's really only been shown to be beneficial in patients with chronic bronchitis. So patients who have cough, sputum production, and frequent exacerbations, in particular frequent hospitalized exacerbations. But if you have a patient that meets that symptom profile, yes, it definitely is an option out there. There are some patients who are not going to tolerate that drug because of gastrointestinal side effects in particular. There is an FDA-approved lower dose that you can start patients on as a means to get them up to that therapeutic higher dose. So that does remain an option, and certainly I do have patients that fit that profile. Another option, as you mentioned, is azithromycin. This is obviously an old drug, around a long time, but we did in an NIH-sponsored study show that for patients with frequent COPD exacerbations or on oxygen, that we did see a reduction in exacerbation frequency with azithromycin. But just like with roflumilast, you can see GI side effects with azithromycin. The other things that you have to be aware for are the potential for QT prolongation, as well as a small amount of hearing loss that was reported in the study. So, and then I guess another thing which wasn't actually discussed in the study, but something else that I do think about in clinical practice is that we do have some patients with COPD who are at risk for nontuberculous mycobacteria. So if I'm thinking about starting azithromycin in particular, I usually get a baseline EKG. If there's any concerns about hearing loss, I'll send them for baseline hearing tests. And then I often will consider getting a CT scan ahead of time just to make sure that there isn't concern for any NTM infection before starting. So there are some caveats there, I think, with both, but they are both things that are available to physicians to think about should the inhaled therapies not be enough.
Absolutely, and that was just a great summary of who and where and when. Milan, in a previous podcast, I spoke with Dr. Barbara Yan, a primary care physician, about applying GOLD guideline recommended care to her patients. Specifically, how do you make that diagnosis, especially in the COVID era? And how do you decide on which initial therapy is right for your patient based on the GOLD classification assessment tool of A, B, C, and D? Primary care doctors tend to view this very different than specialists, and I just would be very interested in your take.
We've seen so many misdiagnoses and or late diagnoses that we really, really want firm data to establish diagnoses. So yes, COVID has now posed a huge challenge with getting pulmonary function testing, but at the University of Michigan, we now have a big procedure set up. We're doing COVID-19 testing on patients before they come in for their pulmonary function testing. And if you're a new patient with me, the GOLD still recommends getting post-bronchodilator spirometry to establish a diagnosis of COPD. And I've just seen so many patients that are much, much more severe than anybody thought or had a totally different diagnosis. Once I had someone with diaphragmatic paralysis that was assigned a diagnosis of hospitalized COPD exacerbation. So I think by the time they get to me, we have to get the diagnosis right, and I have to stage the patient correctly. And you just cannot do that without spirometry. So that's, I think, sort of the first thing I do. And then the second question is what to do about therapy. I rarely have the luxury of being the first person to attempt therapy in a patient. Sometimes I do, but often the patient is already on something by the time they get to me. So it's not as much establishing an initial therapy as it is trying to figure out how to optimize a regimen that patients are already on. I think if the patient is, mild to moderate, and it really is truly initial therapy, I still think that a long-acting muscarinic antagonist is a great choice. But if you have a patient that's highly symptomatic and high risk for exacerbations, GOLD really gives us 3 options at this point for initial therapy. That includes a long-acting muscarinic antagonist, inhaled corticosteroid, long-acting beta agonist combo, or dual bronchodilator therapy. And there are some caveats as to where you might consider one or the other. For patients that are super symptomatic, you might think about the dual bronchodilator, for instance, CAT over 20. But for patients with really high eosinophils, that's where you may actually want to think about the inhaled corticosteroid, long-acting beta agonist as your initial choice in that high-risk patient group. When we're thinking about extending therapy, improving therapy, that's where GOLD recently made some changes. And now instead of just the one diagram, they've got 2 new diagrams to walk people through what to do if treating symptoms is your primary goal, and what to do if treating exacerbations is your primary goal. And I would say the overarching concept of both graphs that they've got, though, is that the bronchodilators in particular, dual, can be really helpful for high symptoms. But if you've really got frequent exacerbations and a patient in particular has eosinophils over 100, that's where you really may want to think about ensuring that an inhaled steroid is part of that patient regimen.
So this kind of dovetails into the concept of COPD patient types. So the frequent exacerbator phenotype, the eosinophilic endotype, and then asthma COPD overlap. How do you in your own head sort those out, and how does that, once you've put a patient into one of those categories, how does that affect your initial therapy?
You know, it's funny, there's actually quite a bit of debate even among GOLD members right now as to whether asthma COPD overlap actually exists. But I think we've all seen patients that have perhaps really high eosinophils and maybe have a childhood history of asthma and have a lot of bronchodilator reversibility that we certainly think about it, and we all know patients can have as many diagnoses as they darn well want. So I do think that I do think about that patient as sort of that eosinophilic subtype of COPD, and you're right. We are starting to think about these patients a little bit differently. Whereas, you know, you may also see, I actually have a few patients that are listed for lung transplants who have, you know, I have one gentleman with an FEV1 of 11% predicted, and he has not had an exacerbation in quite some time, which is shocking to me. But he hasn't. So it really does suggest, though, that we do have these different patient subtypes, and that's where, you know, for this one gentleman, he is not on an inhaled steroid. I've just got him on dual bronchodilators, whereas I have another patient who has an FEV1 of 65% who exacerbates every time I turn around. And I have him on triple therapy. So I think you are right that we are starting to see some differentiation of tailoring the therapies to patient subtypes.
Absolutely. And I think this whole concept of who are the frequent exacerbators, it's more than just COPD and clearly more than just FEV1. There's social factors. Does this person, are they able to take their drugs appropriately? Do they want to take their drugs appropriately? Are they taking other drugs that are illicit drugs? Are there comorbidities flaring that then make their COPD flare? So I think it's such a complex interplay of multiple social, physiologic, emotional factors and psychologic factors that impact on whether you see that patient coming back for an exacerbation every 6 weeks versus every 6 months or 6 years. And it's not just FEV1. So, Milan, I really want to thank you for taking the time to discuss some of these complex issues with me today on this podcast. I'd like to thank all the listeners, and I hope that we can have the pleasure of doing this again.
Thank you so much, Jill. It's always fun to get to chat with you.
Thank you for joining us today. Remember to go to morningcommutepodcast.com/COPD4 to receive your credit and evaluate this program. And be sure to join us for the next episode in this series at morningcommutepodcast.com/COPD5. where Dr. Ohar will be joined by Dr. Barbara Yan for a discussion about COPD exacerbations. You can also find all 6 of the episodes in this series at morningcommutepodcast.com/COPD.